I'd like to introduce our next speaker. It is Carleen Baldwin. She is a physical therapist here at our Walnut Creek campus. She helps patients recover from musculoskeletal injuries, including sports injuries. She has a special interest in caring for baseball players and other athletes in overhead sports. She's a member of our team dedicated to helping athletes return to play safely after a concussion, as well as a member of our scoliosis team. She earned her bachelor's in exercise biology at the University of California, Davis, and she earned her doctor of physical therapy at Western University of Health Sciences. And she's also earned her certification as an orthopedic specialist through the American Physical Therapy Association, and she is a certified strength and conditioning specialist also. So, welcome, Carly.
Thank you. My name is Carly Baldwin. I'm a physical therapist here on the Walnut Creek campus. I get to piggyback on a lot of what Dr. Chow just talked about. I don't have anything to disclose. I don't have any affiliations. So I became particularly interested on FAIs as a whole, because I suffer it from myself, but when I was studying for my OCS, the CPG that had come out at the time was in 2014. And the CPG is put out by the American Physical Therapy Association. It helps us understand how to best care for athletes, or sorry, best care for patients. But for me, of course, I was more interested in the athletic component of it. And so as I was reading through it, there wasn't a whole lot of information on how to really best care for patients with non-arthritic hips. There was this tiny blurb about how there was a couple sports that they found caused a predisposition to FAIs, which of course piqued my interest. Fast forward to 2023, they have now come out with a new CPG that has a lot more evidence and support for how to care for these individuals, but in particular, these athletes. So just to review, FAI, and I will use FAI and FAIS somewhat interchangeably, but there are two terms. One, FAI is the bony anatomy. FAIS is if someone actually has symptoms with it. So FAI is that abnormal contact between the proximal femur and the acetabulum of the femoral head and or the acetabular malformation, resulting in abnormal contact at the joint. You're going to look at a big number here. This is because it's from a systematic review. So depending on what it was pulled from, 9 to 25% of the male population asymptomatic could be having an FAI versus the female population 2 to 10%. Skiffy, late calf brevis, coxa dysplasia, and osteonecrosis do increase the risk of FAI. It can be a precursor, as Dr. Chow already went over, for OA later in life. That premature abutment into the femoral neck, into the acetabulum between that flexion and internal moment is believed to be the cause of that. So this term's a little bit newer, hip microinstability. Hip microinstability is a mismatch between the femur and the shallow acetabulum causing some structural instability. Think about an overstretching of that anterior capsule or trauma to that anterior capsule, and then that repetitive force into ER causing some trauma to that tissue that's repetitively unstable. Our dancers, our gymnasts, and our golfers, sometimes tennis, tend to be the ones that suffer from this the most. Connective tissue disorders where there's already hypermobility, like ALS, downloads, also might be more susceptible to this hip microinstability. So there's 3 types of FAI: pincer, CAM, and mixed. Mixed being a combination of both. Pincer is more common in middle-aged active females versus CAM, younger athletic males. There are some very vague risk factors, but one of them that's pretty interesting here is that there's a sibling component. That there's a much higher risk of developing a CAM or having a CAM amongst siblings. Also high-intensity sports during adolescence. Now we'll see who was paying attention to the last lecture. What sports, keep this in the back of your mind, have a higher incidence? So I'm not going to talk too much about pincer lesions, but I briefly wanted to go over it. It's more common in your active middle-aged women. The reason I'm not going to go over it is because we're here to talk about young athletes. It's that overcoverage that leads to direct impingement of that labrum itself, unlike a CAM lesion, which is that primary disrupts the chondral surface. Impingements can also cause that microtrauma and calcifications to the labrum. So cam-type deformities is an osteochondral extension into the capital-femoral epiphysis. It causes a decreased head-neck offset and an increase in alpha angle. The consequence is believed to be of the growth plate rather than a reactive bone formation. Higher sports with repetitive impact and increased stress on the physis is believed to be the cause. Abnormal physical extension of that proximal femoral physis in adolescent athletes is being seen in that age group between ages 13 and 16. So this is what we're talking about when we're talking about the physeal extension. There's believed to be a biomechanical trigger that elicits that extra growth. The window between skeletal immaturity and the closure of that femoral head epiphysis appears to be when the cam deformity develops. There's a positive correlation between an increase in the extension as well as that growth period. I really liked this image because it shows you 4 different comparisons. When we're looking at the radiograph here, A is a normal hip. B, you see that dotted line, that's what we're talking about when we're talking about the head neck being a bigger offset, and of course creating a bigger alpha angle, which is the cartoon at the bottom. You'll see because there is that overgrowth, now that angle has changed. The image C is a pincer lesion. You can see that little overgrowth on the edge of the acetabulum. And then D is your hip microinstability. You'll see a bigger gap. I'm not going to go into too much depth of this because it's already been reviewed in some of your prior lectures, but I did want to just mention that we need to look at kind of that component of retroversion and antiversion too. There is a much higher trend of retroversion in these cam-type deformities. Retroversion greater than 15 degrees also shows much larger labral tears. So cam lesions, they're anywhere between 2 and 8 times more likely in athletes than your general population. And again, I've already said this, but young athletic males tend to be the culprits. They also have a higher likelihood of developing OA later in life. So thinking about what sports that could be influenced by this, it surprised me a bit when I read the research, but hockey is overwhelmingly the top. They are 10 times more likely to develop a cam deformity. Basketball was 4 times more. Soccer and football also have higher rates. However, football, it was dependent on the position. Some of them were more likely to have pincer lesions depending on what their actual movement patterns were. One study ruled out running alone as a culprit to causing cam deformities. The reason they think that hockey might have this higher incidence is because of the start pattern when they're trying to push off into that triple extension. But also, alpha angles in hockey goalies were shown to be so much higher. And you'll see in that bottom picture maybe why they might be just a little bit more prone to injury, as they have to do this extreme butterfly position to block a goal. Pincers are more common in Gaelic football, hurling, baseball, ballet, and American football. Dancers in general had a much lower alpha angle. If anyone knows what Gaelic football is, please tell me later because I've never seen it. Training frequency is a big reason that some of these athletes are more predisposed to getting the cam lesions. Competitive play, we're talking training and games, more than 3 times a week in patients younger than the age of 12 were associated with the highest risk. Training for 12.5 more hours a week in soccer increased the risk 2 times fold. The frequency and intensity of training tended to have a greater effect than the actual age of training, meaning if someone had been training for 5 years versus 2 years. Athletes who train at this higher frequency are also just in general more likely to develop the syndrome versus just the incidental FAIs. So we're going to take a little detour. I am a super nerd when it comes to these ball and socket joints. I really like the shoulder. I really like the hip. I really like working with overhead athletes. And I tell my patients often that come in, particularly my baseball players, that they're kind of like these mini superheroes that as they're growing, because their growth plates are open, their joint actually adapts to what they're doing. So throwing activities create stressors that cause adaptive changes in the humeral retrotorsion and shoulder range of motion, particularly in youth baseball players, but this can happen in overhead athletes in general. There's 2 factors that affect this. 1, developmental derotation. 2, adaptive torsion by the muscular forces generated during throwing. So baseball players have to get to that in-cocking motion. And so they create these adaptive changes while they're still growing. At birth, the humerus is in a retroverted position. It starts to derotate around age 8, finishes at around age 16, give or take this person's growth. So that gain in that overall external rotation is important for their sport, but it's because they're throwing all the time that they have that increased humeral retrotorsion, allowing them to do so. So, with someone that has this increase in external rotation, it has to offset. The shoulder is built for mobility. The hip is more built for stability, even though these are both ball and socket joints. The shoulder itself can increase for every degree of external rotation. They can lose a degree of internal rotation up to about 8 to 12 degrees. We get more concerned when it's about 20 degrees. And a loss of 5 degrees overall. So we need to be looking at total range of motion in these athletes because we can't just depend on if it's a loss of IR. That's no longer a reliable measure except for if it's that greater than 20. So we need to look at the total range of motion so we don't create an unstable joint. We know they have more external rotation, so as a result, they're gonna have less internal rotation. So getting back to the hip is very similar in this. We need to be looking at total arc of motion in them as well. Similar to baseball, that increase in the physeal extension seems to be an initial event that precedes the cam-type deformity. It's been described as similar to the glenohumeral joint as well, and that rotational deficit. So there's a contracture of that posterior capsule and the hip and external rotation, stretching of the anterior capsule, decreasing its internal rotation. Internal rotation as a whole, which I'll talk a little bit more, is a big predictor of cam deformities in those with an alpha angle less than 60. Remember, Dr. Chow said over 55 was kind of that marker for a problematic alpha angle. So someone who's not even problematic in the alpha angle yet, if they have less internal rotation, that should be like a yellow flag, like, hey, they're gonna be at risk. So when we're looking at hip total range of motion, we should be looking for an arc about 100 degrees. That's a combination ER and IR together. So again, IR deficits are cause and effect in these cam-type deformities. 27 degrees or less had a good sensitivity of about 81% and was highly specific as well, about 85%, to detect an alpha angle above 60. Studies have shown that athletes with much lower IR are more symptomatic to their asymptomatic counterparts. There's also a strong correlation that a decrease in internal rotation of the hip can lead to ACL ruptures in soccer players. Decrease in IR and total arc motion also increases the athlete's risk of hip, adductor strains, low back pain, hamstring, and growing injuries. This was studied in both soccer and baseball players. So this brings me to how we can actually help them. We need to be doing a really good job of screening. So FAIs consist of a triad of symptoms. The first being that classic anterior hip and growing pain. It can sometimes be lateral and along that hip trochanter as well. It's usually aggravated by sitting and then their activity of choice. Mechanical symptoms, clicking, popping, locking, and stiffness. And lastly, a decreased range of motion, especially in flexion and internal rotation. In this particular recommendation, it said hip IR less than 20, which would be a very small amount of hip internal rotation. But it also said that there is a prevalence of CAM in about 40% of athletes that had it less than 30. So I'd say 30 would be kind of where that 20 to 30 would be where I personally would be of concern. And then positive impingement tests with Faber and Fader. So the recommendation currently is starting with PT, 8 to 12 weeks, and then hip injection followed by surgery. Our PT playbook is going to lay out like this. We're going to treat them similar to how we treat all our athletes. We're going to have them do a good subjective exam and understand their pain and get their history. Along with that, we want to be doing some special tests. This follows very closely to how I would screen a shoulder as well. We want to make sure they're stable first before we go into a pain provocative test. So you'll see that there's hip microinstability test before we actually get into the FAIS test and then get into your other tests like muscle length. Following your physical exam, you'd want to do a functional movement screen, depending on the patient, depending on the setting. I know we have ATCs here today too. This is something that you can do with your athletes pretty easily in the athletic training room, or work with your coaches on having them screen. And then lastly, a functional test battery. This is something I would use more for discharge criteria, when I would decide if an athlete is ready to go back to sport. And then lastly, prevention, and we'll briefly talk about that as well. So hip micro instability, there's an 83 to 90% positive with any one of these three tests. The ABD hyperextension ER test, also known as the hair test, a prone instability test, and then hyperextension external rotation test. These pictures all been taken from a study that you can find in your works cited. However, I will also add the physio tutors do a really good job. I have no affiliation with them, but they do a really good job of videos if you're interested in seeing this being played out. So clinical tests for FAI are not great. They are highly sensitive, not specific. So you want to be doing a cluster of them so that you get multiple results. With that, if someone has a pain-free Fader test, no restriction with range of motion in the Faber test compared to their contralateral side, you can pretty much rule out that they're probably in that population of FAIS. So the cluster for screening is a Trendelenburg sign. So when they're standing, is it dropping? Faber, Fader, a max squat. Foot angle, having them walk in internal rotation to see if it provokes pain, and then external rotation. IR with overpressure, a scour test, and then a restricted straight leg raise test, also known as the Stinchfield test. As you're resisting, do they have pain? And these are just pictures. Again, this is in your works cited, but I would highly recommend also looking these up. Range of motion measurements are crucial. We talked about internal rotation loss can be a precursor here. So we need to be doing good range of motion measures. It's important that you stabilize the pelvis as you're doing it. The tests themselves can be done in supine, prone, or sitting. Whatever you're doing, you need to be documenting how you're doing it so that the next person also is doing it that way, as the interrelator and interrelator is not great on this. Of the tests, supine was proved to be the highest in terms of interrater and intra-rater reliabilities in internal and external rotation. Strength testing, there's 27 muscles that act on the actual hip. So doing a thorough assessment, I won't go into all the details of this, but just going into a thorough assessment of how that person is functioning. You had the opportunity to go to the motion lab. There's lots of different ways to test strength, but getting a really good assessment. So as Dr. Chowlett mentioned, we can't change the bony anatomy on these individuals. So we need to figure out how to teach them better motor control. When we look at the trunk and pelvis, how are they acting on some of these functional tests? Symptomatic patients tend to lack a posterior pelvic tilt and spinal flexion. And so they have more of an anterior tilt and hip flexion to compensate. As a result, that really puts a lot of tension on their hamstrings, which puts them at risk for hamstring injury as well. So if you're only looking at the hamstrings and you're not really looking at the pelvis, of course they're gonna look really tight. So looking at what the pelvis and trunk are doing as well. This goes along with that idea of the cross syndrome, that you're gonna be tight on your opposite ends of this axis, weak on the opposite ends of the axis as well. I won't go into great detail on the functional movement screen because these are all mechanical things that people know already. There's screens out there available like the FMS and SFMA that have a point system for this, but having a functional movement screen to see how they're actually moving. When we talk about an exercise progression, you want to go from areas of non-weight bearing where it's highly stable to areas that are less stable. So you don't want to jump straight into your standing type exercises and giving them some more variability as you go on. Lastly is the functional test battery. Single leg squat test, step down test, star excursion balance test, hop test, and single leg sit to stand. Again, the Motion Lab went through a little bit of this with the step-down test, but there are some ways to kind of quantitatively do these tests and give a good, fair, or poor score based on how they're responding. This STAR excursion test is very similar to our Y balance test that has some normative values. And then lastly, the single leg sit stand test. For 30 seconds, you're trying to see if they can get to that 90-90 position. 10 to 15 is considered normative for 20 to 40-year-olds. So when we talk about prevention, we need to be encouraging our athletes to do a really good warm-up. There's a lot of different groups out there that have come out with dynamic warm-ups for different sports. There's a ton on hockey that are actually on the rink, since that tends to be the highest population with these types of issues. But encouraging them to do some sort of warm-up, especially as they're growing. They're young athletes, their bones grow faster than their actual muscles, and so that they get really tight. So encouraging them to do some sort of hip mobility before they go out and play. The FIFA 11 Plus has been around for a really long time. It was done in soccer players. It's a combination of strength, but also some of these mobility exercises. They recently came out with a FIFA 11 Plus Kids, which is for our younger kiddos. If anything, you can just give this to them and be like, hey, we need to have strengthening on your off season and on your off days, as well as doing some mobility work. Lastly, thank you so much for letting me come today and talk to all of you. I am open to questions if anyone has any.